Just looking at the list.
Yep, John's with us.
Great.
There you go. Nice preamble into it. Well, there you go. I think we'll get started, shall we? So thank you very much, everybody, for joining us this lunchtime for our second in the three-part series on risk and risk sharing across the system. We are recording this session, so we'll make that available to you. I'll put a link in the chat once it's ready on a YouTube channel, so you'll be able to pick that up later on. And I'm sure we'll share that out in other formats as well. So I'm going to hand over to Imogen in a short while. The chat box is open, so anything you want to ask through the presentations, please do that, and we'll come to that. It's more of a conversational session rather than presentational, so we'll come to you as we're able to. But if you want to leave things to the end, that's absolutely fine as well. So I'll be keeping an eye on the chat, and we'll make all those. If we don't get around to any questions that are asked in this session, we'll put those to the speakers and we'll get those back to you after the session. And with that, I'm going to hand over to Imogen, and you can take us away.
Hello everybody, thank you so much for joining us. I know it's a really busy time of year and there's huge pressures. Could everyone put themselves on mute? That would be really helpful. Yeah. Thank you so much. I know particularly with the ambulance strikes today and that a lot of people have been working behind the scenes to make things safe for patients, so thanks for being here. We became aware in sort of the Midlands NHS England team of the 100-day discharge challenge back in July that came from David Sloman in the national team, with an ask of sort of 10 aims for acutes to consider over the next few months to improve outcomes for our patients and patient flow around discharge. We had a look at, I think, number 6, which was treat delayed discharge as a harm, and we thought, how can we do something differently about this that isn't just doing lots of datixes? You know, how does it really lead to some sort of change for our patients to make things sustainably different going forward? And some of our discussions at Region and with ESIS colleagues was considering risk differently, and how do we make support our clinicians on the front line and those managers that support them to think about how we can use risk in a slightly different way. We know that our clinicians are aware of risks to patients. You know, they have to fill in VTE forms, so venous thromboembolism risk forms. They have to fill out falls risk assessments, this sort of thing. But what does that really mean for the individual patient, but also all those patients in need of that bed, so the patient waiting in the community for an ambulance? And how do we balance risks a bit more fairly about the risks of being in hospital as well as the risks of being at home, and really kind of raise awareness of things like the risk of deconditioning, which I think some people sort of are vaguely aware of but don't really discuss with patients. So how do we enable clinicians to really understand the risks and then get them to communicate them with their patients and with each other as teams to kind of make slightly different plans for their patients going forward? As such, we've created a few resources which Becky Rhodes, who's a paediatric registrar, is kindly going to share with you going forward, which we hope might help you in your trusts thanks Becky for bringing those up, might help you in your trusts kind of communicate some of the risks to your clinicians. We don't think it will work just to literally kind of email these out. I think they have to become part of a discussion. We had Ned Hobbs kindly talk in our last session around how at Walsall they've really begun to kind of embed those kind of the language change. So instead of talking about breaches, talking about harms to patients, and how that's got clinicians on board. So it is a bit of a movement as well as kind of education programme, and also we know that clinicians take things in different ways. So some love evidence, some prefer stories, some like a bit of both. So so that's what we've taken. So Becky, if I get you to talk through these slides, which is the resources that are going to be available on our future NHS platform, so we'll share the link for that, and then following on from that, and we've got Ben Owens and John Day, who are both clinicians who will introduce themselves, who've been working on this in their own trusts in quite different ways. So Ben more in the A&E space and John Day further on in the pathway in the hospitals, to talk about their experiences. We've also got some other fantastic ESIS clinicians to draw upon during the discussion. So any questions, as Nick said, please do pop them in the chat bar. Also, from point of view, we are really keen to know who you all are on this call, but it would take too long to introduce yourselves. So if you didn't mind just putting in the chat box who you are. Also, later in the session, I'm going to share a link to Menti so that you can do a bit of feedback on this session. But also, if you're interested in being involved in a community of practice with others trying to make changes, you can put your details there for us to collect up. We're going to have an initial meeting about a community of practice in due course, where people can say what kind of community of practice they would like, and we can work out what would support people going forward. So without further ado, I'm going to hand over to Becky to introduce herself and share the resources we've been developing.
Oh, thank you, Imogen. I hope you can see and hear me okay. So thank you for the introduction. My name is Rebecca. I'm a paediatric registrar by background, so I'm very wary of how busy everything is in the hospitals and the pressures that frontline clinicians face. I'm also doing a leadership fellowship this year with NHS England, so that's how I've become involved with this work. I found it really interesting to be involved with this, and I was first tasked with trying to pull out all the key evidence that would support us to push this as an awareness thing about the harms around the harms that our patients face going through the system, but also those for the clinicians as well and the system. So this first slide is a summary of the key evidence points that have been pulled from papers that have been around for ages. So I recognise that many people know these already, but our aim was to combine them all so it's easy to access and easy to read. Hopefully, the key points on that first infographic are then expanded out here, as you can see, and then the respective references are put alongside for anybody that wants to look them up further. We then converted that into a more positive poster. We recognise that life is hard enough on the front line at the moment without being told about all the negative things and harms that we're putting our patients at risk of, but turn it in a positive way of thinking, well, for every patient that we manage to safely and timely discharge, we help at least 4 others. And we hope that this will be useful as either a start to a discussion on a ward or in an education setting, and this has been generated as a poster that it has been approved for anybody to use if they would like to. The link on there takes it to the Future NHS site, which I'll explain a bit more in a minute. We also are working on, and are very nearly there, with a video which will be 3 minutes long and hopefully give clinicians a little bit of a push, and also that feeling of permission that it's important to focus on those patients that are in front of us, but also to think about those around them who are impacted by them staying in hospital. So with using the story of an older lady called Sarah, who you can see on the far left, she goes into hospital, is looked after by a multidisciplinary team who try to do shared decision making and get her home as timely and as safely as she can, which therefore frees up the rest of the pathway and means that the ambulance is not sat in a queue but actually manages to make it to Zach, who's the young gentleman who unfortunately has a cardiac arrest in the community but survives because of good flow through the system. And what we were really keen of was not using this to create antibodies to patient flow, but helping clinicians to really think on the bigger picture of actually that little thing that I can do will make a difference to many people. So that's the video, which hopefully will be there with time. Linked with that, we created a larger workshop, which maybe lasts between 30 and 45 minutes, with the thought that it could be used on induction or as an educational tool, but discussing with many discharge coordinator teams across the region, we recognise that people don't necessarily have an hour free to attend. So we went forward and slimmed it down to a discussion tool. So we call this a risk discussion tool, where hopefully it's a 5 to 10 minute discussion around a small case. So thought that it could fit in with an activity at board round or a CPD session for frontline clinicians, and just getting people to keep thinking about how can I get this patient home, how can we balance the risk better for my patient in front of me and those around. We've combined a whole realm of resources that already existed to try and put them in an easy to access place, which is highlighted on here. It's on the Future NHS site, which you can find using this QR code, or we'll put the link in the chat as well. And we hope that it's helpful. If you have any resources that you know of that you think, oh, we've not included on there, then please do let us know, because we'd love to include them on there. If you have things that are working really well, equally, we'd love to share learning and help progress this in a way that's good for our patients and also good for us as healthcare professionals too. So thank you very much. I'll stop sharing.
Thank you so much, Becky. That's really helpful. Yeah, we would love to include case studies. So you don't have to write it yourself. If you are happy to have a sort of even 20-minute, half-an-hour chat with me explaining your story, I can always write it up, or Becky, or one of us. So yeah, please do get in touch, because we just want to share that real life learning, because it's theories are always much easier than doing it in practice. So that learning from people that have achieved stuff is really important. I've also just seen Anne-Marie Riley, who I know has also done a lot of work in this space. So thanks for joining us, Anne-Marie. So if I hand over now to Ben, if you are happy, Ben, to have just explain sort of how you've come to grips with this and all your experience over the years, and your top tips would be really helpful.
Thank you. Yeah, so my name is Ben Owens. I'm an ED consultant from Sherwood Forest. I'm the urgent care clinical chair lead, and I also work for ESIST. I do a lot of work around risk and that sort of thing. Bit of a personal journey. I was the ED lead at Sherwood Forest for about 10 years, and we were made one of the KEO trusts, one of the KEO 14 trusts, rated inadequate. Issues with sepsis and all sorts of stuff, which is hard to take, but you go back and look at it and the impact. And I then ended up, as a result of that, being divisional lead for medicine, and I was always of the mindset, I just refer them in, admit them, it's fine, I admit them, they'll get discharged. And actually realizing very quickly that as the divisional lead for medicine, that's not the case at all. And actually how hard, once they're in, it is to get people out. And that was my mental shift moment of, actually bringing them in isn't the right thing to do, isn't it? And actually, with all the CQC stuff going on, actually we have to fundamentally relook at how we're doing things. And that was sort of our personal journey. We've gone from inadequate and whatever else as a trust to outstanding rating, and that's there's a cultural shift that has to happen, and that is around talking about risk to patients, talking about your relative. That's it. If that was your relative, what would you do? They're a really good tester question to throw to people and say, if your relative was admitted to your hospital at 5 p.m. on a Sunday evening, or called ambulance in your house Sunday evening to be admitted, what would you do? Would you put them through the system and let the system do its job, or would you phone a friend and say, my aunt, uncle, brother, husband is coming into hospital, can you make sure X, Y, and Z happens? So talking about making it real to people. So actually saying, if that was your relative, would you accept that? Is it okay to wait for that test? Is it okay for them to wait for that? Pointing out so that a lot of the things that we do in a healthcare isn't always logical. Well, we're going to wait 3 days for that inpatient scan. Well, if either it was urgent, so we've waited 3 days and we've increased the risk to that patient, or it didn't need doing as an inpatient because you were able to wait 3 days for it. So actually, there's a sort of thing about a sort of a contradiction there. If it's okay to wait 3 days for the scan, could it not have been done as an outpatient? So trying to look at some of the contrasts in what we do. There's a real thing about challenging language in the front door we've done around. So you say someone has a failed discharge, the immediate thing is, well, they must be readmitted. It may not be. They may have come back to it, maybe discharged or come back to ED, and actually they can still go home. It may be inappropriate or a misunderstanding why they came back to hospital. Doesn't mean they're automatically get readmitted because they came back. And actually talking about the patient and saying they're a failure, if they overhear that, or the relatives overhear that, then actually that's a negative. If you talk to the ward about you had a failed discharge yesterday, what's the chance of that ward discharging someone early today? It's going to diminish immediately. And so the language and challenging things like not safe. I'm saying it's not safe to go home. So immediately saying, what do you mean by not safe? And no one can actually tell you logically what not safe is. It's not a binary thing. There is a risk of going home. There is a risk of staying in or coming in. What is that risk? And staff go, they often can't articulate it. Well, they might fall, but you will. And then you need to talk about, well, the risk of falling in frail older people is greater in hospital. And if you fall in hospital, there is a greater chance of them breaking their hip than if they fall in their own home. So trying to point out the statistics, but bringing it back to patients, one of the key things we've done in our flow meetings is we talk about ambulance handover times all the time. So what's it first thing in a flow meeting every day? What's the ambulance handover time? Because that is the real risk. The greatest risk in the system is the patient in the community with no healthcare waiting for that ambulance. So we talk about, well, we don't hold ambulances as an organisation, but actually we don't, in the bed meetings we'll talk about if we have got exit block, talk about this is Mr. Jones. He's got a fractured neck of femur. He's now been waiting for 19 hours on a trolley for a bed. So making it personal, making it rather than there are 10 bed waiters. He's an 87-year-old man with a broken hip or with pneumonia. So making it about, we're all healthcare staff are here for patients, and so as you say, not talking about targets. I think it's talking about and the other personal learning for me is about asking patients what risks they're willing to take. And I mentioned this briefly because I asked a Twitter poll this weekend about something, and actually said if you had a choice of either, and none of us could, either waiting for a long ambulance for a long time, being in an ED corridor, or to a cubicle, what would you choose if you had to? And only 2% picked the long ambulance wait. 30% picked the ED corridor, the rest picked to. So patients would rather be in an ED if they were sick, than be crowded. And then our second question, what would it be if would you rather be one over on a ward, and most pick one over on a ward if you need to be admitted than being an ED? So we say infection control says you can't do that, but patients and staff would say I'd rather be in the ED than not. So actually asking your patients and your staff what they would do if it's their relative is quite powerful, because people often give a very different answer to that, to what our practice is, what we believe patients want, rather asking them what they do want, a bit like what matters to me. And they're all little tips. And the final tip is repeating it. You've just got to repeat and repeat and repeat and repeat and make it real and point out the benefits when people go home and that kind of thing. And that takes time, but that does shift the culture away from admission to actually what was the risk of admission. You've got to convince people they have to be admitted, rather than going, let's just admit them like fall. You convince me why the risk of admission is worth it for this patient and for the one waiting. And some of the junior doctors particularly will go, I can't. And if you can't, we shouldn't be admitting them. But I'll stop there and I'll hand over to John. That makes sense.
Thanks, John. It would be great for you. Thanks, Ben, so much for your insights, and I look forward to the discussion following. John, it would be brilliant if you could share your experiences.
Sure. Yes. Thank you, Imogen. Yeah. Thanks for that, Ben. Yeah, I'm kind of at the other end of the pathway, trying to open the back door a little bit wider. I'm just going to share a couple of slides. Hope you're able to see that. So I just wanted to speak briefly about an example of how we might reduce harm by criteria-led discharge. So the reason I do all this is two messages that change my practice. I'm a general physician, infectious disease specialist. And an eye-opener for me is a yearly survey that my palliative care colleagues do to look at, on the 31st of March in any particular year, how many of those inpatients are alive a calendar year later. And it's 2/3 of them that are alive, i.e. 1/3 of them have died. And that, puts so much of what I do into perspective. And then from care of the elderly, physicians and research demonstrating that assumption that the longer we keep patients in hospital, the safer we can make things for them before they go home is anathema because of the deconditioning that takes place. I want to just focus a bit on the issue of inpatient blood testing, to ask the question, what's the harm in another blood test? I see multiple venipunctures as being probably amongst the single biggest causes for prolonged stays in hospital. You know, we could think about harm in terms of making yet another hole in someone's arm, the pain, the trauma, waking them up early in the morning. Although I have to say, as the list of blood test requests gets longer and longer, often our phlebotomists come later in the day, to the point that often we're not able to make decisions on today's blood tests because we don't get the results back in time. And obviously, the more we traumatize veins, the more difficult it becomes, and therefore the more painful it becomes, etc. I'd like us to think about blood tests as being a marker of doctor reluctance to make a discharge decision. Go to one of your wards, open up today's plan, you will invariably see repeat bloods tomorrow on that. And you know, in most of those cases, it's a procrastinating approach, because I don't quite feel able to grasp the nettle today and make this patient medically fit for discharge. So this is a surrogate, a being a little bit rude, but perhaps a semblance of clinical activity that isn't necessarily really. I acknowledge as a clinician that our default position tends to be looking for reasons to keep patients in hospital rather than reasons to discharge them. I think, you know, we need to recognise that that's a key cultural flip that we need to make, and often, of course, the reasons for doing the blood tests are somewhat spurious, particularly, you know, if the previous blood test was basically normal. I think some of it underlines this unrealistic pursuit of normality. None of my patients are normal. Most of them are unlikely to return to a baseline, if we want to consider that baseline to be physiological perfection. And I think often blood test requests lack a clear purpose. Often they're all resulting in unnecessary treatments. You know, the typical one, oh, look, their phosphate's a bit low, let's put them on some phosphate replacement. Magnesium, potassium, a little bit low, let's put them on revolting or oral supplements, without really having any evidence base for someone comes in acutely unwell. That's fairly typical for them to have a transient drop in their phosphate, potassium, and sometimes magnesium as well. I'm not saying that there isn't a case for replacing, but the oral supplements are particularly unpalatable and can often impair diet. And of course, delays in discharge, you know, keeping patients in, starting them on antibiotics, and then, you know, in an abnormal test result means we've got to do another one to check that they're improving. So here's an interesting article that I was really very pleased to see, and you know, in particular the fact that it was the cover story. I'd really recommend, if you want to look at this in a little bit more depth, looking up this article, which looked at the question of routine inpatient blood testing, and a piece of research that's been done in the States, really looking at what the impact is of doing inpatient blood tests for patients where there isn't a clinical indication for it. I'm not against blood tests, you know, for patients whose clinical condition requires it. And they end with this really nice kind of what they describe as education into practice, with some challenging questions for clinicians. Number one, what makes you uncomfortable about limiting the order of routine repetitive lab tests? Secondly, how often have you changed management in response to these tests? And thirdly, what strategies do you think would successfully limit unnecessary blood testing at your hospital? Big questions, not easy answers. But again, I want to come back to one of those first points that I made, that I think underlying this needs to be a cultural flip to say that we need to make our default position that patients, you know, if we've not found a reason not to discharge a patient, sorry, double negative, then let's not be looking for one. And finally, really just to link this with clinical criteria for discharge, I think the key thing about blood tests is that we need to anticipate what we want to be different. Yeah, sure, do a blood test, but what are you looking for? Which particular tests, given that a multi-channel analyzer will do about 30 different tests, most of which you haven't actually requested by, when you request for U&Es, what are the specific ones that you're interested in? What are the parameters that you want to achieve that would stop you doing blood tests and discharge the patient? And 3 different ways of recording this, handwritten in the notes. We want the creatinine and the neutrophil count to be less than what they were, or we might specifically say that the creatinine needs to be less than 100. Rationale there being we tend to follow that improve to within 25% of baseline. This is the sticker that we use, and then more recently we're using an electronic method on nerve center, recording this with a method for changing it from no to yes once we've achieved those parameters. Thank you.
Thanks so much, John. It's such a practical step. I think sometimes when we think about delayed discharge, clinicians in particular think about, oh, well, we just can't get them out because there's not a social care bed, or there's not this or not that. And I think that just shows something that clinicians can actively do differently themselves. I think I'm really mindful that we're at a time of a workforce crisis, and our teams are working really hard. And I think one of the things that we know from various pieces of work, including Professor Michael West's ABC of what really promotes professional well-being is autonomy, belonging and competence. And I think one of the things is enabling people to have that autonomy and giving them that ownership of what they can do to make a difference. And when they're feeling quite done too, that can be really powerful. So I think how we share the messages in an empowering way is also something we need to be really mindful of, rather than it seeming critical. So I think that's another challenge us in this space have got to think about, is how we deliver these messages in a really supportive manner. And I think the other reflection I've had from hearing both of your talks, also me being a GP and working out in the community, is how do we support each other to really understand what services are available in our different spots? So I think another thing I certainly felt as a junior doctor working in a hospital is I didn't really know what was out there for my patients in the community. So sometimes that fear of sending them out because I wasn't sure what they would get. Will they get the physio? Will they get this? Will they get that? And I was quite interested recently. I work in Coventry and Warwickshire, and there's a professional curiosity scheme running. I don't know if that is happening in other systems, but where you can do job swaps for a day between secondary, community and primary care, and sharing that learning and understanding of each other. And again, that's just another idea that I've had recently that I thought could really help in this space. I'd love to bring you all in now for some more discussion. I know a lot of people, John was saying they really thought that blood testing was a really useful topic. Ben, could I bring you in?
Yeah, thank you. No, and just to pick up, I mean, the word that the phrase of what John's discussing is the reassurogram, which is a test you do to make the doctor feel better, rather than the patient. We do it quite a lot in medicine at times. Is your comment about sort of learning each other? A common thing I say to people is, what would a GP do? Are you doing that test because they're here, or are you doing it? Likewise with some of the, I need a therapist to assess their ability, and you say, well, what do you think a GP does? And it goes out to someone in the house who's fallen over. They don't go lie on the floor, and in 2 days' time a therapist will come along and tell them if they can stand up or not. You just let them get on with it. So there's this thing of what comparing and contrasting what happened in primary care and not. Just a comment around when people actually say, I'm not doing that, I can't do that, I don't want, or people may want to change behaviours. And a really good challenge, or perhaps make them see where the risk sits, is to say to people, can you give me a patient-centered reason why you're not going to do that? And if they can't, then we're going to do it again, aren't we? And people go, well, I suppose so. And I give the example. So we have a rule in the hospital that everyone referred or anyone's take is seen, has to be seen before they go home. So no one's hands over to the night take. The day takes day, so everyone see. The late takes everyone to see from the on-call take point of view. And the contrast of risk is, in an outpatient clinic, no consultant will go, it's 5 o'clock, it's time to go now. Bye, the last 2 patients will have to come back tomorrow. like a GP surgery, you see all the patients. So why, if you're on call, would you go, it's 9 o'clock, I'm off, sorry, the last 4 patients I have to see tomorrow? These are undifferentiated sick on call patients who are undoubtedly weller than your clinic patients. Why would you walk out of the door? What would you for your relative? And if people have said, well, I'm not doing that, I don't do it, you should, well, give me a patient-centered reason why not, and I'll happily let you walk out that door right now. And of course they can't. So I see sometimes just holding the mirror up to people can be really powerful. I think that mirror is also what would happen in the community. Is a really good way from a cultural point of view of pointing out to people sometimes actually often it's I'm not saying I can't take that risk, or whose risk is it? It's actually the patient's risk, not ours. And holding that up is really powerful sometimes.
Imogen, just so you got Martin from George Eliot, who's got his hand up as well.
Oh, brilliant. That's super helpful. One thing I was just going to highlight quickly was the other thing this has made me think about is how we share the messaging, and just also to raise awareness of the Recondition the Nation, because I think the other thing is that we can share messages in quite serious ways, but we can share them in more fun ways as well. And I feel that Recondition the Nation has really shared the idea of sort of deconditioning broadly, and has been really picked up. Particularly East of England are leading the way in this, but also the Midlands has done quite a lot. And I just wanted to share that that's been another way of sort of, I guess, sharing a sort of change in behaviour through a bit of fun. And I think sometimes we think when things are really bad in the NHS we all need to be really serious, but I actually think a sense of fun sometimes brings joy to people at work, and actually can make them do a lot more things, and so that can be really powerful. Martin, can I bring you in?
Yeah, sure, Imogen, thank you. Yeah, just a couple of points to make. Fascinating presentations, and really glad to hear them. So thank you all very much indeed. Particularly loved John Day's thoughts on blood testing as an excuse not to discharge a patient, or to avoid that difficult discussion with the family or whatever it happens to be. I guess there are a number of points that I think underpin our reluctance to discharge patients and our problems with doing so. And that gets into the culture and underneath this. So some of it's the fear of litigation, of difficult families, of complaints, of criticism, and we don't necessarily do enough to dispel that. Another is that uncertainty, that lack of knowledge about what is actually possible in a community. So as secondary care doctors, we often think that the person we see in front of us with the aftermath of an acute illness, whether it be a simple one or a more complex one, cannot possibly manage in their own environment. And we often make decisions about people's ability based on that snapshot, and don't necessarily recognise that folk often adapt so much better in their own homes and avoid so much of the sequelae of landing up in hospital. Very much as Ben had been saying, the only area where I disagree with Ben's comments is that he's talked a lot about risk, but actually it's a risk-benefit equation, it's a balance, and people often have an inappropriate understanding of the benefits. So we see on every second television program the fact that no matter what you go into hospital with, you come out singing, dancing, and doing cartwheels. And we know that's absolutely not true. So the public have an expectation, but actually we as professionals also start to have that expectation. I've rambled too much, Imogen, as you know, I have a tendency to do that. But the final point I wanted to make was a bit about futility. So there is an awful lot of difficulty recognising the issues around futility. That 6th course of intravenous antibiotics will not make any more difference than perhaps the 2nd. But we do it because, you know, life is precious. We don't want to feel we've missed any opportunity, understanding that people dying sometimes is part of the process, and actually trying to sustain a miserable life is probably not doing our patients a service. I'll shut up, but thank you for listening.
Martin, I think that's really helpful, and I think it's also a push to us in the community, particularly to do more sort of care planning for people in the later years of life. And I certainly feel as a doctor that at times we, as a GP, we don't always have time to do the care planning we would like to do, end of life care planning, and that challenge to ourselves also of you know, would you be surprised if this person was dead within a year? And if not, you should have done some sort of plan with them and made that. And I think that would really help. And I know that, you know, COVID has made it more complicated for us even more in the community. But again, that's a challenge as a system to think, how can your primary care and your community care be doing more sort of shared decision making with patients ahead of them hitting the front door of A&E, because hopefully it might even prevent an ambulance conveying them in the first place. And it would support families to have thought about these things in advance as well, to kind of, because I think a lot of the cultural changes is not just us as clinicians, it's patients and families understanding that there's going to be a shift as well, and that hospital isn't the safest place to be always, and that kind of thing. So I wondered if I could also bring in Anne-Marie Riley. And Anne-Marie, I know you put a few points in the chat, but I wondered if you wouldn't mind actually drawing them out verbally, because I think that you've got a lot to share as well, and that would be really helpful.
I'm doing it off the hoof because I'm not expecting to say anything. So there's a few things for me, and I've put one of them in the chat in terms of how much data organisations have about what happens to people when they're in the hospitals, particularly around deconditioning. And I'm guessing it'll be very little. So very few trusts capture it as a harm event on Datix. The best that you will see is a falls reduction chart that will go to your quality governance committee. Well, we can make those look better just by stopping people walking. It doesn't mean that they're having good or safe care. We very, very, very rarely report the deconditioning harm. So it's about how do we build that into the systems you've got already. So we've just introduced, and most trusts will do it, some sort of monthly audit tool where you're capturing whether you've assessed people when they came in and how they're doing throughout their stay. And we've built questions in there to say, has somebody lost functional ability? Has somebody lost continence function? You know, the simple things that you can pick up and then act on when you spot it. But you can educate people as you're doing that. It's one of the key elements in our quality strategy. We're in the process of developing a range of harm-free care ambitions, and part of that is changing the language. So instead of falls prevention, the ambition is safe mobility, because what we're trying to do is keep people walking safely. And we've put some of these in the resources so that people can just you just put your own thing on if they're helpful. But again, it's that cultural change, but building it into your everyday work, because I think the worst thing you can do is try and do this as a campaign that we have a lot of focus on, then we move on to something else and then it just dies off again. We educate people on the induction around deconditioning, what it means, what we're trying to do. Have we got it perfect? No, we haven't. I mean, Jane's my new deputy, so she'll know. We've still got a lot to do, but we've got the right foundations now to be able to start to, make it, it's an important factor that is one of our quality markers. We're capturing harm, and we've got guidance to be able to tell people what the right thing to do is. A lot of what John said rang true. So we did a review the other day, myself and the Chief Operating Officer, just trying to understand who was in our beds. Probably like a lot of trusts, were in perpetual crisis with you know, ambulance halts and all sorts of things. So we did a review of every patient with a news of 2 in all our medical wards, medically fit or not medically fit, because I think we find that we've got risk averse decisions about declaring people medically fit, so that's not a really good marker quite a lot of the time. And we split into 2, and both of us found between 30 and 40 patients that we said should not be in this hospital. That was just in medicine. So that element around being risk averse rings so true, and it's driven a lot of discussion about what we need to do in terms of educating people. We had so many examples of people can't manage at home because of the limit of care that can provide in people's home. That's quite normal. You know, double up 4 times a day isn't that abnormal in community, is it? It seems strange because you've got 24-hour care in a hospital, but it isn't in community. And it's prompted a whole breadth of discussions around what we should be saying to people when they come in, and not putting suggestions of care or writing people off and saying they've got no potential really early on in their journey, because we've got other pathways we can optimise people on, and acute setting is probably not the best one of them. I'll stop there because see Ben's put his hand up.
Thanks, Anne-Marie, for sharing, and sorry to pick on you, but I know you have a lot of value to add. Ben?
Yeah, so I mean, I totally agree with what Anne-Marie said about a particular thing around measuring positive things, and you got to measure positive things to get positive outcomes, but also that repetition thing. You do have to repeat this stuff. People have to hear or do things up to 16 times before it becomes embedded. So talking about these things is really important. But a comment on language is really important. And actually, I have a really strong belief around this is not people being risk averse, because they're not being risk averse. They're actually creating risk at times with their decision making. They go, well, I'm a risk averse, and actually it's their, if they're being a little bit more strong, they're being risk blind. They're not seeing the risk. I can't discharge that patient what if something goes wrong, and in doing so they're increasing the risk for that patient and several others down the chain. And it's really hard, and actually it's not to criticize that person, it's just like perhaps people just think differently. They're not being risk averse when they say they're being risk averse. They're actually creating more risk. They're not intentionally doing it. They're not out to do that, but actually they're not being risk averse at all. They're almost blinding themselves to the risk that they are creating. So it's about how we can get people to change that mindset by talking to them about that and nudging them. You can nudge people along that journey, and that takes time and repetition.
Thanks, Ben. Richard, do you want to come in?
Yeah, hi. Just to kind of comment on the risk aversion is a great term that we've adopted, and I suppose I'm just being a bit linguistic about it. It often has, as Ben describes, a little bit of a label. So Dr. X is risk averse, which almost is a judgment. I think we all have a different risk threshold. So I guess in human factors, that's the terminology, and that risk threshold can only really be altered by the individual based on information received. So I think Anne-Marie's point about confidence in the community, I think Ben's point about working with somebody to understand why they may be taking a particular approach is probably just to broaden out how do we help people to be optimal at making decisions, considering perspectives and doing other things. So I guess it's just a thought around trying to make sure we don't use that term in an identified way for particular people, because, for example, I don't like heights. It doesn't mean I'm risk averse. It means my threshold is to not be any higher than a step ladder. and no end of you telling me that I'm not going to fall may have any bearing on that. So I guess it's just trying to do as you are doing, keeping this kind of positive and real, because the complexity of trying to discharge somebody is way more complex than we think, and we can be at risk sometimes of being a bit linear and going, well, I could have sent that patient home, but you didn't see the patient. So I guess just some balance.
I think that's really helpful. And Richard, you've touched on human factors, but I know it was new to me when we spoke, so I think many people aren't that aware of it. So I don't know if there's any good resource people could we could share in the chat, and we'll make sure we put it on our futures page as well, just so that if people wanted to look into that a bit more. I think it's really, really interesting and about behaviour change. I also just wanted to join. I think, you know, one of the reasons this subject is so difficult is it's complicated by so many factors. But the other one I was going to say is a hierarchy, which is the other thing that I think is a big issue in healthcare. And I think that feeling of you know, people feeling somebody more senior than them needs to make the decision, and that kind of disempowerment of people beneath that. And I think that's another thing that when people are thinking about working on this, how you think about leadership from all different levels, and people kind of having ownership of their space and enabling them to speak up. So that, for example, at a board round, it's really meaningful because people can be devil's advocate, people can challenge, people can speak out, so that the best outcome comes to the patient. And I think one of the ways to share that is by bringing it back again to the patient, because that is the one thing everyone can agree on, is that should be the priority. So whatever is best for the patient. And but I know that that's really, really challenging. And I certainly, as a junior doctor, felt a huge sense of hierarchy and that my role was very limited by that. And I think that's a shame. And it would, I think, have an added benefit of retaining more staff if we could smash that down a bit, because I think it would be positive for all. Nick, I can see your hands up.
Just to say, obviously, we're drawing to a close, and it's coming to quarter to 2 now. Just want to just sort of thank everybody. But one point for me was really about, I think touched on before, it's never the individual. People don't come to work to do a bad job. It's understand the environment that's happening around them, and that's what obviously Richard referred to. And people talk about, and finger pointing is never helpful. So it's finding that one thing that we can do. So the challenge for everybody here on this call today is, what can we go away from here today? Just one or two things that we can do differently. It's not there's no silver bullets anymore. They've all gone long time ago. It's those simple things. One thing that we can do just to start to help people, encourage them to feel comfortable in their decision making, because it's often the environment that the people work in that leads to some of the decision making that we've spoken about today, which may appear to be, and I'm going to say the word risk averse, Richard, but it may come across in all different ways. But it's understanding what's happening around the people, and I think Anne-Marie referred to that really around how do we help people to feel more comfortable, more psychologically safe, to make those decisions, because ultimately I just wanted to sort of reinforce that it's very rarely the people, it's the environment or the processes that they work in. But I'll hand back to you, Imogen, to wrap things up for today.
Thanks very much. We will close now, even though I know there's a few hands, because we said we would at 1:45. So thank you so much for all your contributions. Please do fill in that Menti survey so that we can keep making these as useful as possible for you. And also do look at our future NHS, and please do share any positive examples with me. And if you've got any ideas for future sessions, that would be fabulous. So thank you so much for everyone that's contributed. And I think, the impact you're having on patients is fantastic, and it's a really tough time. So anything we can do is brilliant. So thank you so much, and see you at the next one, which is the 26th, I believe. So see you then.